Hi, good morning, good afternoon, or good evening, whatever may be the time you are looking at this video. It's very nice to see you all through this video. I know I took a long time to push these videos. This time I thought of doing the lung pathology video in parts, and I did this for 39th annual national virtual CME in pathology at JN Medical College at Belagavi. So I thank the organizers for being part of their conference and allowing me to put these videos. And this is, as I told you, practical pulmonary pathology. It goes for I think 2 hours. So I am breaking them into half an hour videos so that you can see it in parts. I hope you all will like it. And if you have any comments or any healthy criticisms, please mention it in the comment area, and I will see it and respond to it positively. Thank you very much, and again wish you all to have a great time. Bye. To 2 hours, we will have fun, a case-based discussion on practical pulmonary pathology. And this is my objective. I always want to start with histology of the lungs, and then there is a common thing that is used in lung pathology known as 6-pattern analysis. I don't know how many of you know that. I follow the whole lecture in the 6-pattern analysis platform. We will go through the selected cases and we will end it up with molecular changes, and I will give you some take-home message and references. And I want to start with the references. These are all the 4 references I want you to keep it note of it. 6patterns.org, top at iarc.fr, France, and they are the people who sell the blue book. And pathellective.com and USEAP.org 2021 annual meeting. Unfortunately, this USEAP.org 2021 annual meeting is the material is not available in the internet, but all the other things are there. The 6-pattern is mainly by Dr. Kevin Leslie, and he also had a book on that, practical pulmonary pathology. In fact, I borrowed my topic title from his book, Practical Pulmonary Pathology. And as I told you, the blue book, you are all very fortunate that I am able to get that beta version in that shop. It's a 70 euros payment annual subscription, and all the blue books are available. I strongly recommend you to go to shop.iarc.fr and pay the annual subscription. All the blue books are available there. It's an annual subscription of 70 euros, and I don't have any financial connection. Please don't think I get money when you become the subscriber. I just want to share it with you because I loved it. Then the other very nice reference is the pathellective.com, and this is the pulmonary pathology web page. They have all the AP, all the modules, GIT, GYN, all the courses are there, and they have nice videos. So I kindly, if you are not seen that, please visit pathellective.com. Pathellective.com. Take a shot of this. Super. So to start with the histology, you all know the lung develops in the embryonic period and then fetal period and then during birth and postnatal growth. Some practical points are there. First thing, it is known as embryonic from weeks 3 to 7, pseudoglandular in 7 to 17, canalicular in 17 to 27, saccular from gestational week of 27 to 36, and it is more like alveolar in weeks 36 to up to 10 years. By the age of 10 years, we all will have a fully developed lung. In the pseudoglandular phase, we will have glands. If somebody says this is lung, nobody will believe. And probably you all might be doing the fetal autopsy and you might have seen these things. There's a lot of mesenchyme in between the glandular epithelium. And one thing you have to remember, the fetal type of adenocarcinoma will exactly resemble the pseudoglandular pattern. That you keep it in mind. Next one is canalicular. If you put some air in the gland, what will happen? It will become a tube, and that is what canaliculi means. They are all tubules and they come together, and the mesenchyme in between will become less in number. So this is the spectrum of changes. The mesenchyme will reduce in amount, and the air space, supposed to be the air space, they get bigger and bigger, and they come closer together to the blood vessels. And this is the saccular phase. You can see the alveolar spaces more dilated, and the mesenchyme has reduced much in amount, and the alveolar phase almost look like a adult lung. And the viability is there only when the baby is from the saccular phase. That's why it's very easy to reduce the mortality when the babies are born after weeks of 27. So that also you have to keep it in mind. How do you remember this thing? I imagine the balloon which is not at all aerated. So this is known as pseudoglandular. And when there is mild amount of air, it slightly increases and become tubular in size. So it is known as canalicular. When you increases the air in the canalicular space of the balloon, then they will become saccular. And when you keep on increasing the air, then it will become alveolar. So please remember pseudoglandular, tubular, saccular, and alveolar. The practical point there is the pseudoglandular pattern will be recapitulated in fetal type of adenocarcinoma, and the viability is very good after the saccular phase. Coming to the histology, lung is also divided into functioning units. Remember, in the liver we talk about the unit hexagonal plate. Like that, in the lung it is more pyramidal or round shape, and each in the center will have the airway, bronchus, and the pulmonary artery. Pulmonary artery and the airway, they go together, and it is in the center. Whereas the pulmonary vein and lymphatics, what happens there? The blood goes to the alveoli, gets aerated, and then it passes through the vein into the various branches of the vein, and it forms the septal vein, and then it comes to the interlobular bronchial vein, and pulmonary vein, and it will have the lymphatics also there. So the practical point you have to remember is artery and airway, they are always paired, and they will be of uniform in size. Whereas vein and lymphatics, they run in the pleura and the interlobular septa. Why we have to know that? The diseases affecting the airway and the pulmonary artery, they occupy the central portion of the functional unit, whereas the one that involves the pulmonary vein and the lymphatics happens in the pleura and the interlobular septa. The example is here hypersensitivity pneumonitis, because the antigen come through the airway, the fibrosis and the granulomas, they are seen in the center. Whereas in sarcoidosis, it is predominantly affects the lymphatics and the venous system, so they happen in the pleura and the interlobular septa. And this is the cross section of the trachea or bronchi. Why I say that is because of the cartilage. Trachea and bronchi will have the cartilage, and they will have a pseudostratified ciliated lining epithelium, and then lamina propria, submucosa, and the muscularis. And in the posterior plane, the cartilage will be deficient, and we will have lot of glands, salivary type of glands. Why we have to know that? This is the origin for the salivary gland type of tumors in the trachea, bronchi, or in the central portion of the lung. What happens in bronchioles? The cartilage are not there to support. So the mucosa is thrown into stellate shaped corrugations, and cartilages will be absent. So this is bronchiole. So you should be able to differentiate trachea and bronchi from bronchioles by the absence of the cartilage. So this is the peripheral portion of the lung, and this is the interlobular septa, and this is the pleura. You can see the mesothelial lining on the outer side, that is the visceral pleura, and see the alveolar spaces, and they are all connected, and these are all the alveolar septa. Some of the alveolar septa are having congested blood vessels. Please imagine the vessels running in the septa are the veins and lymphatics. For example, take this area into high power. So these are the lymphatics and these are the veins. So as I told you, the veins start in the alveolar septa. They go into the interlobular septa and then pleura, and they traverse through that and they go to the main pulmonary vein. And as you know, pulmonary artery carries the bad blood and pulmonary vein carries the good blood. This is the highest power of a well-developed lung, just to show you the thinness of the alveolar septa. You hardly see anything. Then only the diffusion of the oxygen and carbon dioxide can happen. Okay, this is the type 2 pneumocytes. The alveoli are having two types of pneumocytes. One is flat type 1 pneumocytes, other one is epithelioid type 2 pneumocytes. It's very difficult to see what are there in the septa, but this cartoon will help you to see that this is the alveolar space and this is the alveolar space, which are lined by type 1 pneumocyte and type 2 pneumocytes. And this is the alveolar septa, like here. And in the alveolar septa, you have the capillary lumen and the endothelial cells, and few scattered interstitial cells are there. The applied histology of this is, whatever disease happens in the lung, we have to see, is it occupying the alveoli or is it occupying the interstitium. One easiest way of telling that from the clinical features, whenever alveoli are infected, they produces productive cough, whereas whenever the interstitium is involved, it produces dry cough. And this is a neuroendocrine marker, chromogranin. Normally we have scattered neuroendothelial cells. We don't have the exact, we don't know the exact function, and you can see the ciliated cells at the terminal bar nicely in this high power. I just want to show you the normal neuroendocrine cell, and it is above the basement membrane. This is the basement membrane. This concept is very, very important. I will be talking about that, but I just want to give it a small intro here. When you see the neuroendocrine cells above the basement membrane, it has to be either normal or hyperplastic. Hyperplastic neuroendocrine cells, remember that diffuse idiopathic pulmonary neuroendocrine cell hyperplasia, it has to happen above the basement membrane. It cannot come beyond the basement membrane. When it comes beyond the basement membrane, depending upon the size, it will become either a tumor-like or carcinoid. We'll see it again when we talk about it. Other components of the lung in the normal area is the lymphoid cells. They may be seen around the airway or in the periphery, and these are known as mucosa associated lymphoid tissue. Scattered lymphoid cells and lymphoid primary follicles can be seen, and these are all the cells that give rise to maltoma. Why you have to know the histology is that knowledge is very, very important to know what are all the other tumors. By just going through the histology, you know maltoma can happen, neuroendocrine tumors can happen, salivary gland tumors can happen in the lung. So we need some clinical information before looking into the specimens. Patient information like age and gender, disease onset. This is very, very essential, whether it is hours to days, acute, weeks to months, subacute, or chronic from months to years. In the radiology, there are mainly 4 patterns: reticular, honeycombing, ground glass, and nodular pattern. Some of the pathologists, they insist that we should know the radiological features, but I think the world is improving so fast, even following the advancements in pathology itself is difficult. So it is very difficult to follow up the radiology literature also. So what I think is we should have good friends who are updating in radiology, and we will learn from them rather than learning from the books. Coming to this portion, what are all the specimens we can get from lung in pathology? One is expectorated material, for example, sputum. Other one is bronchoalveolar lavage or brush cytology specimens. The third one is needle biopsy. It is guided, either ultrasound guided or CT guided biopsies. PET guided biopsies are also happening now. Bronchoscopic biopsies, either transbronchial or endobronchial through EBS, endobronchial ultrasound guided procedures. Surgical lung biopsy is also known as video-assisted thoracoscopic sampling, segmental or lobectomy or pneumonectomy, and explants in cases of transplant. These are all the 7 types of specimens you can receive in the pathology lab. Radiology is part of gross examination. You cannot omit radiology, not only in lung, in any organ. Before seeing the slides or after seeing the slides, you have to always correlate with radiology. The best thing to remember is radiology is part of the gross examination. And seeing the radiology report won't help. You have to go down to radiology and you have to sit with them and discuss them. Then only you can learn from them and they can learn from you. Please remember, radiology is part of the gross examination. So when you get the wedge resection specimen, remove these clippings and you inject formalin gently and fix it. Or after removing the clip, put it in the container and vigorously shake. You are not able to see anything here because this is taken when there is a vigorous shaking happen, so that the formalin can go into the air spaces. That is very, very important to preserve the tissue. For example, there are 2 sections here. In the top one, you can see the architecture very nicely. So this is where you can see the architecture very nicely. Whereas here it is a very ill-fixed sample. You cannot see the architecture very well. Now, I am coming to a very important practical approach, how to check the lesions in the lung. Any lung lesion falls in this 6 pattern. Either they fall in a pattern where there is alveolar and septal involvement with some fibrin and eosinophilic material, and this is known as acute lung injury pattern. The second one is the alveoli looks normal here, but some bronchial metaplasia, but there is a lot of fibrosis in the interstitium, and this is known as pattern 2 or fibrosis. And here there is a lot of infiltrate in the interstitium predominantly, so this is known as pattern 3 or cellular infiltrate. Here you can see the alveoli are filled with eosinophilic material, so this is known as alveolar filling pattern. And here it is seen like a nodule. Okay, the background lung looks normal, but this one looks like a nodule, so this is known as pattern 5 or nodular pattern. And here it almost looks like normal, so it is known as normal pattern, pattern 6. So this is the pattern based approach in pathology. There are 6 patterns, and the pattern 3 and pattern 5, they looks more blue, whereas pattern 1 and 2 and 4 in the low power will look pink, and the normal one will look pink and blue. All the diseases will fall under either one of this pattern, and let us see the 6 patterns. So this is the lung tissue where the septa is slightly edematous and some inflammatory cells are there, and some fluid is there in the alveoli, some cellular infiltrate is in the alveoli, but there is no fibrosis. So this is known as acute lung injury pattern, which is pink in color, and this is characterized by interstitial edema, interstitial fibroblast proliferation, alveolar edema, alveolar fibrin and cellular debris, and reactive type 2 pneumocytosis. And otherwise this is known as diffuse alveolar damage. You can see the hyaline membrane, you can see the interstitial fibroblast, you can see the interstitial inflammation and reactive type 2 hyperplasia. So this is diffuse alveolar damage. Diffuse alveolar damage is characteristically have 3 patterns, 3 stages: exudative, proliferative, and fibrotic. In the exudative phase, all the edema happens and peaks in day 1, whereas the proliferative phase, where inflammatory cells will be more, that peaks at day 6 or 7, and the transition is where the hyaline membrane is formed. It peaks around 2 to 3 days. Fibroplasia starts at day 2 and keeps on increasing as the day goes by with progressive fibrosis that undergoes either stable fibrosis or resolution. These phases you have to remember. You should not think diffuse alveolar damage is only hyaline membrane. It is one of the phases of the diffuse alveolar damage. Here you can see a lot of pulmonary edema, fibrin thrombi in the capillaries, and type 2 alveolar macrophages, and fibroplasia in the septum in cases of organizing pneumonia. In this acute lung injury pattern, there are 9 subtypes, those associated with hyaline membrane, with granulomas, with background fibrosis, with neutrophils, with hemosiderin laden macrophages, with foreign material, with eosinophils, with cellular interstitial infiltrate, with necrosis. I'm not going to go through all the conditions, but there are 9 subtypes in pattern 1, and this is given in that 6pattern.org. Whenever you see foreign material, for example, look, is there any aspiration or embolized drug or chemotherapy agents, or is there any silicone pneumonia when there is acute lung injury with foreign material? So these 9 subtypes you have to remember in pattern 1. Clinical information is very, very important in cases of all acute lung injury to identify the cause. For example, history of systemic disease, history of serological studies. For example, autoimmune diseases can produce acute lung injury, so we have to know the serological studies also. There is a mnemonic to remember the associated causes of acute lung injury. Imagine the name of the girl is Deb, and what is Deb doing? Deb is doing fishing. So you see Deb fishing. So that's the mnemonic. See Deb fishing. Okay. C is for connective tissue disease, D for drug reaction, E for eosinophilic pneumonia, B for bleeding or diffuse alveolar hemorrhage, F for foreign material, I for infection, S for scarring with background fibrosis, and H for hypersensitivity pneumonitis. This is a very nice mnemonic. I love it. Again, I am borrowing it from 6pattern.org. Unfortunately, we don't do autopsies in COVID patients, but this will be a favorable exam question for the next 3-4 years. So I thought I will just put, when we are discussing acute lung injury, the causes of or the findings of lung in COVID-19 autopsies. It is in the interstitium, in the airway, and in the blood vessel. In the interstitium, it is diffuse alveolar damage, acute inflammation, lymphocyte inflammation, multinucleated giant cells, pneumocyte hyperplasia, and viral inclusions in the pneumocytes. In the vessels, it is microthrombi and endolithiasis. In the airways, it is chronic bronchiolitis, acute bronchopneumonia, and fungal lung infection. So these are all the changes you see it in COVID autopsies. I will just give 1 second to take a shot of it. Whenever I want you to take a shot, I will give you 5 seconds. Okay. So this is pattern 2, where you see a lot of fibrosis, okay, and remodeling of the alveolar spaces with the bronchiolar dysplasia. And there is fibroblastic proliferation at the junction of the dense fibrosis and almost normal appearing alveoli. So this is pattern 2 or fibrosis, and because of the fibrosis in the low power, it will look like pink. And whenever you see fibrosis, you have to see whether it is patchy or diffuse, because patchy is more characteristically seen in UIP, usual interstitial pneumonia, or idiopathic pulmonary fibrosis, whereas diffuse you see it in non-specific interstitial pneumonia. Okay, honeycombing you can see it in any end organ lung disease, end damage of the lung. Smooth muscle dysplasia or smooth muscle metaplasia is one of the findings you see it in pattern 2, along with fatty metaplasia and some fibroblastic foci. It's very, very characteristically seen in usual interstitial pneumonia. So what I want to use that terminology, cirrhosis of lung. Normally, when you take a biopsy of the lung, it will be smooth surfaced, okay, with functional lobules. Whereas here, it is a very rough surface and it is more fibrosis, looking like cirrhosis of liver. So this pattern 2 is characterized by cirrhosis of lung. And again, whenever you see fibrosis, you have to see, is it seen in the pleura and interlobular septa or around the bronchi? Okay, when you see around the bronchi, you have to look for pathogens in the airways, for example hypersensitivity pneumonitis. But when you see the fibrosis along the pleura and in the septa, you have to think of etiology in the blood vessel. Okay, for example UIP or autoimmune associated interstitial lung diseases. There are like 9 patterns in 9 subtypes in pattern 1. There are 7 subtypes in pattern 2. Scarring with diffuse alveolar fibrosis, honeycomb only, airway centered, pleuritis or lymphoid hyperplasia, acute lung injury, granuloma, and variable involvement. Please refer 6pattern.org for this. Now we are moving to pattern 3. As you all know, this is heavily infiltrated by cells, so it is known as cellular infiltrate, and because of that, this will be blue in color in the low power. This shows 7 subtypes with lymphocytes and plasma cells, with focal organizing pneumonia, with granulomas, with fibrin and hyaline membranes, with neutrophils, with pleuritis and or lymphoid hyperplasia, and with fibrosis. So there are 7 patterns in 7 subtypes in pattern 3. Now we are moving to pattern 4, where the alveoli are filled with eosinophilic material. Alveolar filling, pattern 4, it will be pink in color. When you see the pattern 4, there are 8 subtypes with eosinophilic material, with granulomas, with organizing pneumonia, with the giant cells, with the neutrophils, with the blood or siderophages, with the macrophages, and with the atypical cells. The main thing in eosinophilic material, 2 things you have to remember is alveolar proteinosis and pneumocystitis, Jervosi pneumonia. Okay, and when you see atypical cells, you have to think of neoplasm, where the we will be STAS we will be talking, spread through air spaces, where you can see the atypical cells in the alveolar spaces. We are moving to pattern 5 now, which is the nodular pattern, and this is the main pattern where we get the lung. But the only thing is, all the other patterns we get either wedge resection or lobectomy or pneumonectomy, bigger samples. Whereas in nodules we get the core biopsies, that you have to remember, because here the lesion is present as nodules, they go for core biopsies. Again, there are 8 patterns with necrotizing granuloma, with non-necrotizing granuloma, with organizing pneumonia, with lymphoid cells, with necrosis, with dust, with stellate scar, and with the atypical cells. In the necrosis, I want to get your focus on this concept. Necrosis can be seen with the infection or in the lung with venous granulomatosis. In infection, the necrosis will be pink and nodular, whereas in venous granulomatosis or granulomatous polyangiitis, the necrosis will be blue in color and it will be geographic, very irregular outline. Finally, we are seeing the normal pattern, pattern 6, which will be pink and blue. Here, I told you during histology, the airway should be accompanied by the pulmonary artery wherever you go, and the diameter is more or less the same. When you go to the periphery, the airway diameter will become less. Similarly, the arterial diameter will also become less. So this is like husband and wife. Airway should always be with the blood vessels, and whenever you see only airway or only blood vessel, there is a problem. There are 4 subtypes in the normal pattern, with vascular diseases, with cysts, with no specific findings, and with small airway disease. So this is the Leslie 6 pattern of pulmonary pathology. This is Dr. Kevin O. Leslie, and this is Dr. Smith. They both are from Mayo Clinic, and I thank them for stimulating me to get interest in the lung. And they also have a worksheet. Okay, whenever you get a lung biopsy, you get a worksheet. and this will be more useful in a non-neoplastic lung biopsies. You can tick whether it is pattern 1, 2, 3, 4, 5 or 6, and then in that what are the associated features. The minute you are clicking them or ticking them, you will get the diagnosis at the end of it by having a look at it. So thanks again to Dr. Leslie and Dr. Smith.